All my colleagues and distinguished faculty and chairpersons. I'm going to present two cases of left main thrombus which occurred during osteal LAD stenting. So the first patient is an 80-year-old man, hypertensive, presented with recurrent anginal episodes of 1 week duration, diagnosed as anterior non-Q MI, admitted for coronary angiogram and possible PCI. Echo showed moderate LV dysfunction. He was preloaded with EchoSprint 75 and Brillianta 90 into 2. The radial route was opted, 6 French, and 5,000 units of unfractionated heparin was given. And here is the angio. So this, I can just narrate what happened. So I have done the angiogram which showed a osteal LAD very tight lesion, and then I pre-dilated the lesion and then put in a stent there. And then when the stent was deployed, which was very well deployed, there was a small thrombus noted at the bifurcation. The patient was hemodynamically stable, but this on injection you can see that the thrombus was moving. And then it was a concern there how to deal with this thrombus. So there are three options. One is to aspirate the thrombus, and second one is to infuse 2B3 inhibitors intracoronary and then subsequently IV infusion. And then another option was to balloon plaster the thrombus or dislodge it. And finally, if it is not yielding, then thinking of a stent. That was the last option because it is a bifurcation left main and the procedure would be complicated. So here I have taken a balloon, 2.5 small balloon, and then tried to push it down. Then in the initial attempts, it did not yield. And subsequently, I dilated the balloon at low atmospheres at the stent partly and into the left main partly. And then after that, what we found was the thrombus got dislodged from that site and then migrated distally into the LAD. So that saved the situation. This is the case. And the another case is a 44-year-old male, acute anterior wall STEMI, treated with streptokinase at an outlying hospital and referred for further management. Echo revealed mild LV dysfunction and he was referred for CAG and possible PCI. So in this case, femoral approach was used, preloaded with EchoSprint and clopidogrel, and 5,000 units of unfractionated heparin was given. And the guide shot revealed osteal LAD lesion again in this case as well, and it was a significant lesion, treated with a 3x28 Zions Pro stent. And again in this case, similarly, we found a thrombus at the distal bifurcation of the left main. And then the options remain the same. First is aspiration, glycoprotein 2B3A, balloon plastering or dislodging, and lastly, to consider a stent if it is not yielding. Interestingly, in this case also, the patient was hemodynamically stable, fortunately. So here we have given intracoronary aggramate, and then I took a balloon, because this case has actually happened back to back within a few days of time. So with that previous experience, I tried to do the same thing here, and then we took a small balloon and then tried to plaster it. Then here again the thrombus got partially dislodged. It did not go away completely, but we put the patient on infusion of aggramate and also heparin overnight. The patient remained stable, then discharged home safely. So unfortunately, I could not show you the thrombus size and how it was appearing very clearly on the angiogram. So in summary, intraprocedural coronary thrombus is a well-recognized complication during PCI, especially during ACS cases. Anticoagulation may mitigate the problem, but if persisting, may need additional interventions like thrombosection, balloon plastering and dislodgement, or stenting. In the case example, balloon dislodgement, which was a simple procedure, and plastering helped to save the situation. Thank you very much.